Good evening, everyone. So today I am going to talk about few mistakes that we commonly encounter, both either in the stroke diagnosis, in first investigation of choice, whether it is CT or MRI, and later post-stroke rehabilitation. So when it comes to the initial high stakes of stroke care, so the misdiagnosis rate is 10%. So what are the common things we misdiagnose regarding stroke? Either it can be we mistake with any BPPV or seizure disorder or hemiplegic migraines. So with these things we can often confuse. So most oftenly, what are the other symptoms of the stroke that we commonly don't see? We commonly see for deviation of angle of mouth and weakness of one upper limb and one lower limb and sensory loss. But if the patient comfortably lying on the bed and the power is 5 by 5 in all the limbs, we commonly uh, mistake seeing for incoordination of the limbs. So as soon as the patient begins to walk, he falls immediately on one side of the body. The power will be 5 by 5, but the patient unable to walk. So it is ataxic hemiparesis rather than the plain hemiparesis. So it is a frank stroke and the patient needs the thrombolysis if it comes in the window period. So apart from the ataxia, other things we miss is one is hemianopia. So during the routine evaluation, we examine the extraocular movements and the facial deviation, but we routinely miss the hemianopia part. And apart from these three hemisensory laws also, patient doesn't frankly complain why my one side is numb, but if we examine, the hemisensory loss can be present. Yeah, one is improper imaging choices. This is very important because if patient presents within the first 12 hours or in hyperacute phase, both bleed and infarct looks similar in the MRI. That is, the infarct looks T1 hypointense and T2 hyperintense, and the bleed also looks T1 isointense, T1 isointense and T2 hyperintense. Until and unless we see SWA images and GRE sequences, we cannot diagnose with 100% sure that is an infarct or bleed. So we can thrombolyze the patient who is having a hemorrhage if we solely rely on MRI itself. So better to have a CT immediately after when patient presents with the stroke symptoms. Then it is better to go with MRI. And if CT is showing a hypotenuse area, then we likely that it is a infarct. And still we have doubt. And if as the MRI takes more than 20 minutes, we can have any two sequences. That is flare sequence and DWS sequence. And these two sequences are also useful when the patient presents with the wake-up stroke. So when patient presents with the wake-up stroke, two things are possible. Suppose if patient is waking up at 6 a.m. So the one possibility is patient had a stroke at 5 a.m. when the patient is asleep and patient is woke up at 6 a.m. and he observed the weakness of the one side of the body. So this patient is amenable for thrombolysis. Second scenario is patient had stroke at 10 p.m. itself the previous day and patient woke with the hemiparesis on the next day 6 a.m. So this patient is, the thrombolysis is not required because he is out of window period. So at that time we are often confused whether the patient has stroke at 10 p.m. or 5 a.m. So at that time we can do one thing, MRI with DWA flare reversal. In these patients, if the stroke has occurred recently, there will be DWA restriction but the flare will be normal. So these patients are amenable for thrombolysis and thrombectomy procedures. And errors in the thrombolytic therapy. One, there are two, alteplase and tenecteplase. For alteplase, we have to give 10% bolus and rest of the infusion over the period of the 1 hour. And for tenecteplase, we can give infusion over, slow infusion over the 5 minutes. So these precautions has to be taken by giving thrombolysis therapy. And the contraindications has to be checklisted. So we have to maintain a checklist, whether it is a physical checklist or a mental checklist, whether any contraindications are present for thrombolysis or not. Even the patient denies saying, suppose he is a chronic alcoholic and chronic liver disease patient. So he doesn't say, if we until and unless we provoke and ask. So in this patient there is already predisposing bleeding disorder with the liver disease. So in that patient, if we go with the thrombolysis, patient can have frank bleed. So instead of doing favor for the patient, we end up doing harm for the patient. So like this, every contraindication has to be ruled out. And next mistake is mismanagement of blood pressure in the acute stroke. So in the first 24 hours, from the highest blood pressure, 15% more, not more than 15% of the blood pressure should be reduced because cerebral autoregulation will be impaired. So in hemorrhagic stroke also, within the first 24 hours, there are different guidelines. Some guidelines say in hemorrhagic stroke we should not reduce more than 15%. but some guidelines say we have to bring the blood pressure to 140 by 80 mm of mercury within the first 24 hours. So each guidelines have its own merits and demerits. But in ischemic stroke, if you are going for the thrombolysis, the BP has to be reduced to 185 by 110 mm of mercury. And if the BP is more than 185 by 110 mm of mercury, if you are not willing to thrombolysis, we can decrease the by 15% in the first 24 hours. And neglecting early neurologic consultation and stroke team activation. So as soon as the patient comes to the emergency department, so within first 20 to 30 minutes, the patient has to be diagnosed as stroke, the first imaging of chest has to be done, and the respected consultant physician has to be seen, and the imaging has to be diagnosed as stroke, and thrombolysis has to be ready for the thrombolysis. So with this timely activation of stroke team and the stroke protocol, the number of neurons can be saved. Inadequate management of risk factors, either it may be diabetes, hypertension, and smoking, or whatever it may be, and inadequate intake of the antiplatelets, because most of the patients they present with the secondary strokes, they will say that doctor has said to use antiplatelets for only 1 month, then I have lost follow-up to him. So we have to we have to make an emphasis on the patient that you have to take these medications lifelong. Otherwise, there is a risk of second stroke, and for which the implications will be more severe. And post-stroke rehabilitation is also important. As soon as the patient is diagnosed with stroke, within 24 to 48 hours, we have to maintain an active rehabilitation program, especially in patients with bulbar palsy and speech disturbances. Because and even the thrombolysis guidelines is if NIHS is between 5 and 25, the patient has to be thrombolized. And even if patients with NIHS 1 or 2 can be thrombolized, that is when. Suppose if patient is a singer or a teacher, he is most relying on his voice for his employment. So even though the patient is having slurring of speech and the limb power is 5 by 5, and if CT or MRI is showing an infarct and patient came in the window period, we have to thrombolize, because the stroke is affecting his speech, which is important for his employment. So even though the NIHS is 1 or 2, we have to thrombolize him. And if the patient is having mild weakness, suppose a dominant hand, and the patient employment is relying on his writing, and because dexterity loss will be more, even the strength is 5 by 5, as the dexterity loss is more, we have to do thrombolysis, even the power is 4 plus by 5.